Welcome. In this explainer, we're diving deep into wrist and hand fractures. We're going to focus on the key patterns and management principles that you absolutely have to know for the clinic. Let's get right into it.
So here's the game plan. We'll kick things off with a quick overview. Then we'll walk through the big-ticket fractures. The scaphoid, the metacarpals, and the phalanges. And then we'll wrap it all up with the key things you need to remember.
All right, let's start with a classic question to get the gears turning. Keep this one in the back of your mind as we go, because the answer really shines a light on one of the trickiest and, honestly, most frequently missed injuries in the hand.
Okay, Section 1, the big picture. We're going to start with the one single mechanism of injury that kind of ties all of these fractures together. Understanding this is absolutely fundamental.
You have to remember this acronym, FOOSH, a fall onto an outstretched hand. It sounds simple, right? But this one event is the common thread that links so many different breaks, from the wrist all the way down. Getting a handle on the forces involved here is really step one in making a diagnosis.
And that brings us right to Section 2 and the answer to our little pop quiz. The scaphoid. This tiny little carpal bone is famous for all the wrong reasons. It has a well-earned reputation as a real problem child.
So, spotting a scaphoid fracture starts with being suspicious after any FOOSH injury. Your number one clinical sign, tenderness in the anatomical snuffbox. You press there and the patient jumps. Now here's the tricky part. Standard x-rays can miss it. That's why you need a special 4-view scaphoid series, and honestly, these days a CT is pretty much routine to be absolutely sure. Now, when it comes to treatment, you've got a major fork in the road. It all comes down to displacement. If those bone fragments haven't moved, you're looking at a long, long time in a cast, like 9 to 12 weeks. But if there's any displacement at all, that's a ticket to the OR for surgery, usually to place a Herbert screw to really squeeze those fragments together.
And this is why it's the problem child. This is the slide you can't forget. The scaphoid has this really weird backwards blood supply. Because of that, it is super vulnerable to avascular necrosis, where the bone tissue literally dies, and non-union, where it just refuses to heal. If you miss this or mess up the management, the patient is almost guaranteed to get debilitating arthritis down the road.
Okay, let's move distally to the metacarpals. This is where you get all those classic eponyms, the fractures with names which are actually super helpful for remembering the different patterns.
This little table sums up the big three you have to know. So, Bennett's and Rolando fractures both happen at the base of the thumb. The main difference? A Rolando is cannulated. It's shattered into multiple pieces. Then you've got the boxer's fracture. As the name suggests, it's a break in the neck of the fifth metacarpal, from punching something you probably shouldn't have.
So how do we treat these? Well, it really comes down to stability. If the fracture is stable and everything's lined up nicely, a cast for 4 or 5 weeks will usually do the trick. But if it's unstable, displaced, or involves the joint, it's gonna need surgery. And for open fractures, an external fixator is your friend for getting things stabilized early.
Pay attention, because this is probably the most important point about metacarpal fractures. It's so easy to miss. You have to ask the patient to make a fist. Normally, all the fingers point towards the scaphoid, but if one finger crosses over another, that means you've got a rotational problem, and that is a huge deal for function. It has to be fixed.
All right, last stop, the phalanges, the finger bones. Now, treating these can seem really straightforward, but don't let that fool you. The risk of a bad outcome, specifically a stiff finger, is incredibly high.
For most of these, if they're stable and not displaced, the plan is pretty simple. First, you check for any rotation or angulation, just like with the metacarpals. If that looks good, you can often just buddy tape the injured finger to its neighbor or use a little splint for about 3 weeks.
Of course, surgery is an option, but we save it for the gnarly ones, the ones that are unstable, can't be put back into place, or are broken into a bunch of pieces. In those cases, we'll use tiny plates, screws, or K-wires to get everything lined up perfectly so the patient can start moving early.
And this quote right here is the whole story. This is the key takeaway for finger fractures. Unlike the scaphoid, where we're terrified of non-union, the real enemy here is stiffness. The biggest challenge is preventing that loss of motion that can happen after even a minor injury. Early movement is everything.
All right, let's wrap this all up. Time for a rapid-fire review of the absolute must-know clinical pearls. This is the stuff you want to have burned into your brain.
Okay, here are the word associations. You hear scaphoid, you think snuffbox tenderness and avascular necrosis. You hear Bennett's or Rolando, you think base of the thumb. You hear boxers, you think fifth metacarpal, and you immediately check for rotation.
And for phalanges, your one and only thought should be stiffness, stiffness, stiffness.
And we'll end with this clinical picture. If you see this after a repair, you know exactly what's going on: rotational malunion. Catching this, and better yet, preventing it, is absolutely critical for preserving the incredible, complex function of the human hand.